Welcome to Global Talks by PavLyfe, a podcast about redefining healthcare through a global perspective, allowing you to become informed and involved. In each episode, we deliver the best hard-hitting analysis and discussion of what is currently impacting the healthcare landscape, with guests from a variety of industries. Now, here's your host, Pavan Lohia.
Welcome back, and thank you for tuning in to today's episode with my special guest, Dr. Jonathan Unkart. Dr. Unkart is a board-certified physician, epidemiologist, and an assistant professor at the University of California, San Diego School of Medicine. Today, we're going to be discussing the epidemiology of COVID-19, its impacts on the healthcare system, and what we can do to be better prepared for the next pandemic. Without further ado, please welcome Dr. Jonathan Unkart. Thank you so much for joining us, and welcome to the show, Dr. Unkart. How are you doing today?
Excellent. Thank you. How are you doing? You staying safe over there?
It's been busy in New York and DC, but definitely trying to take as much precaution and staying safe to the best of my ability. It is a difficult time, though, and I'm sure you're experiencing it as well. How's everything down in San Diego?
Excellent. I think we're doing pretty well overall in San Diego and California in general. I was just looking at the calendar, and I think it was around March 13th, that Friday the 13th, where kind of things to me, I was like, okay, this is a big deal here in my backyard in our country. We're gonna have to go social distancing, physical distancing, and my wife is joking that I kind of overreacted at first, and I was like, I'll take the heat for that. I'll be okay. I'm starting to talk to my family. We really got to stop, doing things as usual here.
Of course.
Stay at home and things like that. And I think we're seeing the benefits of that in San Diego and California. Cases are still going up, but it's going up slower than we've seen in other places.
Yeah, absolutely. And I think, you bring up a great point about the cases. Being here in New York, we obviously the epicenter of the disease outbreak, just the last numbers that came out, we had close to 7,000 dead and, over now 170,000 cases just in New York alone. And, there's different models of that are predicting, either that the peak is going to come much earlier, or some are even saying it's going to come much later. And as having a background in epidemiology and public health, what do you kind of see of these models that do exist? Are you kind of seeing that we are approaching the peak, or is it still yet to come?
Yeah, so I'm not an infectious disease epidemiologist, but thankfully I had some classes when I was doing my MPH on this, and generally reading the literature every day because I'm a little anxious about it. I think a lot of people out there are, but the things I look at, we hear this talk about the peak and flattening the curve, but I also look at the duration of how long that upslope is going and then that peak, because we're concerned with the peak, especially in terms of capacity of our healthcare system.
Right.
And that we in California are, I think, near that peak in terms of where we might start to see it flattening out. But then the question is, with the peak, is how long, in the horizontal axis with high numbers of cases are we going to see it as well? And so I'm using my arm, and I'm realizing now at the podcast, and no one's going to see this. We really want to avoid that sharp uptick.
Of course.
Because that's a lot of disease spreading rapidly, and then a lot of taxing on the healthcare utilization in various places, some places better equipped than others. But then we still have this long, tail as well. And what does that really mean too? And so what we're trying to do, at least by flattening the curve and delaying the peak the best we can, or at least the plateau, is, that buys us more time to do more research in terms of investigating a vaccine, an effective treatment, what's the best way to roll out the reintegration into regular life, what's our testing strategy going to be. And so I'm encouraged to see the recent models, and with there's a lot of assumptions and a lot of input. And since we're working with this in real time, you gotta understand that. But what we're at least seeing is the number of projected cases and the number of projected total deaths are coming down for across the country. And I think that's a good sign. I think that's a good indication that the majority of the country is taking the physical distancing seriously, and we're going to, at least in this first wave, kind of have it taper off and not be as dramatic. Hopefully it's not similar to what we saw in New York. Hopefully we won't see that in too many places.
Right, and I know California has had that benefit of, while it still has close to 20,000 some cases, the overall deaths have been significantly lower for being, as nearly as populated as, or a bigger state than New York has been. I do think social distancing has played a critical factor in that, and California took an early lead, both the state level and throughout multiple counties. I know, for example, San Diego County was one of the first to implement the mask wearing, compared to just recently. Now you have the country start wearing facial masks, and it kind of brings me to the question. I think your experience is very unique because I'm sure you've probably never experienced something of this magnitude. But also just, given your vast background of being a new physician, or not relatively, having different areas of expertise. So, just to give my audience a little glimpse of that, how is kind of just being, having a more hands-on view in terms of being younger, being more knowledgeable of the dynamic of medicine and public health. How have you kind of utilize that to your benefit in COVID-19?
Yeah, because until really COVID-19, my expertise in both clinical medicine and public health kind of functioned very differently.
Right.
Different goals, they have different leadership structures, different funding structures. And what we're seeing here with the COVID-19 outbreak, and luckily I'm young enough not to have been alive in the 1918 pandemic, because I think that's probably the closest outbreak that this country can relate to in terms of the scale and scope. But what I'm really seeing now is how the public health, especially the policy level, and the healthcare system really come together. And what do I mean by that exactly? And I know we were talking a little offline before the show, is how in a normal day, even going back a few months ago before all this started, public health is all about, disease prevention and planning for what if. And
exactly.
It happened, at least here at the local level, in the United States. We've had scares overseas with, Ebola and SARS and MERS, H1N1 even, briefly appeared here. But for the most part, during my clinical experience, and I'm 36 years old, thankfully, we haven't really had to deal with much of an outbreak that really kind of went coast to coast. And so a lot of the stuff I do for public health and prevention focused in isolation from the healthcare delivery system, which is almost really focused on you already have a disease and
exactly
read that here. What we're seeing now is these things trying to work together in real time. And then it's a nice kind of picture of how, unfortunately, dysfunctional it can be at times here. So we have a lot of public health measures and really aggressive, strategies about testing and distancing and things like that. And we're really seeing an impact directly on the healthcare system in terms of not overloading our emergency rooms, our ICUs, our ventilator capacity, and things like that. And so I think we're going to learn a lot of lessons, a lot of experiences most of us in the medical world as well and public health world have not experienced.
Right.
It's fast, it's moving quickly, it's a little scary at times. I definitely was anxious at first. I've kind of reached a new normal level of anxiety that makes me a little more productive now. But I think, and I'm hoping actually, when we have a little more clarity in the rearview mirror from all this, when we're looking at it, a year from now or 2 years from now, the real importance of public health and how it needs to be integrated within our healthcare system overall.
Of course. No, I couldn't agree more. I think for so long you've had public health, not prioritized, underfunded, and just that relationship of public health and medicine. It is really good to see more physicians have a background like yours, a MD and an MPH, and being able to kind of use those in conjunction and especially, you're in a university environment at University of California, San Diego. I've spoken to, the medical directors from UC Irvine and other UCs themselves, and just the perspective of dealing with younger, for the most part, younger adults, but also you have entire administrative staff, you have faculty, and then you have other external visitors and stuff. So in many ways you get a very niche community to look at and also get experience with that. Which I'm curious, in terms of being a professor at UCSD, I'm sure you've had to transition online. So for those new medical students, what are they kind of learning from this, and have they even been asked to partake in helping in the response?
Yeah, and it's a moving target at each institution with that. I'm thankful right now I'm not teaching a class lecture style at this moment, because there was a huge rush to get everything online, get everything
right.
home. And what the cardiovascular disease epidemiology class that I teach in the fall, I think the strongest component of that class is the group discussions in person with the experts I bring in, and just the ability to have that personal interaction. I don't think you can fully replicate that in the digital space. There's something in the same room with people. And the part with medical student education, there's some controversy about how best to utilize medical students during this pandemic.
Right.
Medical students are paying a lot of money to learn on-the-job training that's going to serve them for many years to come. But there's also a do no harm if we're struggling with the amount of personal protective equipment that we have, and we have to ration that. Should we really be having medical students who aren't critical to the delivery of care at that point in time? Their presence is always appreciated, but is it actually riskier for them to be involved there? And there's trade-offs with that. You don't need as much PPE, but you're losing a member of the team, and you're potentially losing valuable experience. And so a lot of the medical students that I've talked to have tried to find other ways to really take a community approach. They're volunteering with the county department like me. We're doing some great kind of fundraising drives where they're actually trying to get people to donate PPE from the community. I know there's a big contractor presence here, and they actually have a lot of masks, and these medical students were able to go out in the community and have a lot of people deliver some of that PPE. And thankfully, we haven't run out in our local hospitals yet as well. And so it's just inspiring to see what the medical students have, kind of been told, maybe we don't need you directly in patient care. And, that can hurt your feelings a little bit, but we're really in unprecedented times. And it's really about community, what's the best that can be done. And them going out and getting some of that PPE could make all the difference, especially if we're, talking a couple months out from now, if we still have pretty high circulating levels of this virus. That could actually be more critical than doing that one-on-one thing that they, I'm sure want to be participating in.
Yeah, and I think, I've definitely seen a lot of innovation just come out of this crisis. It's great that you mentioned the students getting involved. Just in the last episode, I spoke to a former UCSD medical student, now physician, who's in their MBA program at the Rady School of Management. And he's actually leading efforts to print 3D masks. And I was involved in helping, also donate to that campaign. And they've been able to deliver masks all around Southern California, throughout the past few weeks. I just spoke with them earlier, and they're, building more and more kits to have reusable masks that would serve as effective N95 masks, which I think that's really great to see. And especially the community fundraising part, myself included, gathering that PPE, other critical supplies, face shields. Those are, I think it also highlights a need to, have these things produced in, a number that actually a state needs, whether, not just in the time of a pandemic, but, just in any health emergency. I think this is a great reminder of what we need to prepare for moving forward. Exactly. Ultimately, also a lot of our vulnerabilities as well. I think the phrase that has been recently used is, from the outside, we've always prided America to be very safe, but on the inside, especially our health, it's showing that we're not safe and protected as we so think. And, seeing these images come out of, whether from the mass graves in New York City to, the storage, the back of truck trailers being used as, makeshift morgues. It's truly heartbreaking, and even seeing California, the pictures coming out of California, the stress on their hospital and EMS workers. It's quite eye opening, and I think for as far as the disease goes for itself, where do you kind of see the future of this? There's talks of different waves. China has just recently eased a lot of their restrictions on the public. I know Wuhan just opened up just a few days ago, actually, and things are slowly starting to get back to normal, but still there's a lot of checking. There's fear of asymptomatic adults walking around and possibly having another surge. And I think that's a fear that many people have now, right?
Exactly. And I think I'd make a lot of money if I was a betting man in this case. I just don't have a good grasp of what the next few months, the next couple years even might look like. I can give a sense of what we need, right? So we know this virus spreads pretty easily from person to person, and does so even before a person becomes symptomatic. One of the main differences between the first SARS viruses, where pretty much once people became symptomatic, that's when they became really infectious, and they were able to isolate people, and they were able to limit the severity of that outbreak. But what we're seeing here is people are potentially infectious a couple days before they even show symptoms, if they end up showing symptoms.
Right.
A lot of asymptomatic transmission, especially countries like Iceland and South Korea that are able to do community testing, where we test you not based on whether you have symptoms or not. We're just testing you just to get a sense of what the distribution of the cases are in the population. And what we're seeing is a lot of younger people in their teenage years, in their early 20s, have a high rate of being asymptomatic infection. And so once we ease off the social distancing and think about going back to the usual way of life, where kids are in school, we're going into the office.
Yeah,
it's all going to come back,
absolutely.
Right? The transmission, and if we have to do something different in order to prevent another significant peak and wave of this outbreak from happening. And so, what does that actually entail? And from a public health perspective, it really comes down to testing and effective, reliable testing. One, we need to know who's immune to it, and that involves a complex interplay of one, having antibodies, for example, present to the disease, but does that presence of those antibodies actually confer protection? Meaning, if you were previously exposed or previously infected, you recover and you have these antibodies. If you came into contact with someone in the grocery store, for example, that is newly infectious, are you protected in that sense? We don't have the answer to that yet. So that will be a big question to answer. But then also we need rapid testing and scalability, where people like you and me, we might be feeling good right now. We should get tested every week, every 2 weeks, so we can, one, check for asymptomatic transmission, and then once we are able to identify new cases, have a robust system of isolating people away from others.
Right.
And the strategy is to stay at home, but for a lot of people, you're living with a lot of other people who are coming in and out and interacting with other people. So we really need to develop another strategy there. And this is what we're trying to do right now. And this kind of stay at home physical/social distancing time is kind of come up with a game plan to really ease off the social distancing measures, so we don't overload the system again and have another big peak like we're seeing right now.
Of course. And, I think testing is a great area that you bring up. There's been so much discussion around testing, especially, just the experience I've had being in New York and being in DC. I've gotten a lot of questions, both from people at my hospital, and obviously people who have contacted me for information or advice. What is the testing that's available? Who can get it? And what is it telling them? I've heard people tell me that, oh, there's a test I can get that'll tell me in 15 or 20 minutes if I'm positive, or on the other extreme where I've heard, oh, okay, well, I can get a test, but I'm not going to find out for 10, 15 days. And then, looking at the numbers themselves, the amount that have actually been tested of the ones we've received samples for is actually relatively small. Just the other day when I was looking, it was somewhat of around 55,000 tests of the 330 plus thousand that have actually we've taken samples of have been tested, which is relatively small compared to that number, and that number is only going to drastically grow. So, I think there is some clarification that needs to be made on testing. So I don't know if, so how would you kind of say, what should we know of what testing is actually out there and who's actually able to get it?
Right. And testing is a tricky and moving target right now.
Of course.
Definitely not something we should be proud of as a country at the moment.
Right.
Here, the issue with testing was originally the CDC had basically said, all right, all the testing has to be done by us. And they have public health labs around the country that can coordinate that. And
right.
If you take a sample, say in San Diego, and you have to ship it to Atlanta, where CDC headquarters is, that could take a couple days. They have a way of doing the test. The rollout of that was kind of
botched.
Right, exactly, right. And so that opened up the floodgates in terms of commercial testing. So all these companies coming out with their own tests, or the healthcare systems developing their own tests.
Right.
I want people who are listening to this to know that no test is perfect.
Exactly.
But there's always, false positives, there's false negatives, and we're going to see a huge range of that across all these tests. And it could be the test itself, it could be the way you collect the sample, whether it's from the nasopharynx or you're doing a blood test. And so one of the issues is we have the availability of different tests being, limited in certain areas, more available in others, but there's so many different types of tests out there as well. And so are the results comparable from test to test? So there's a couple issues. There's availability, and there's the consistency and reliability of those tests. And unfortunately, right now, and at least the first early couple of weeks, were people who were really sick weren't able to get tested. And so in some ways, it's helpful to know that they got COVID-19. But the treatment that we have is all symptomatic, supportive right now. We don't actually have a therapeutic. In some ways, you almost want to test the people who aren't as sick, the people who are going to be out in the community moving around. Because if someone is really ill and they're in the hospital, you can isolate them. And you recover, you can isolate them at home. Or if someone's not feeling good, you can tell them to stay home. But what about the mildly symptomatic individual? And the criteria for a lot of the testing centers right now is very stringent. You have to have had a known exposure or a travel exposure in the past, or have these certain symptoms, which basically up to the severity of the case that in order to get tested. But those people were more likely to have the COVID-19 as you increase their pretest probability in that way. And so we're still flying really blind from a public health perspective of where the cases actually are.
Absolutely.
Now, friends and colleagues in the medical profession, and just friends across the way who have had symptoms that are consistent with COVID-19 that haven't been able to get tested. And I think a lot of people probably know someone either in their own family or their close social network that is experiencing that. And so just that description right there of the testing challenges show you how far we have to go in order to reopen up normal life, or even roll out a resemblance of that.
Yeah, and I think just apart from testing, when we look at how we've even given the information on the testing, from the federal response of at one point saying testing is available for everyone and anyone who wants it, which was clearly not true, and is for the large part not true even now. There was kind of this fear, and it kind of just feeds into more information. People then panicking of well, I might have it, and you're right. Yeah, obviously, you and I may have more stories to tell of I do know this person, and I've heard these stories, but even just to another degree from our friends hearing different stories that have been kind of told back to me, and I'm sure you've heard some yourself. It is quite interesting. When I spoke to colleagues along the East Coast, and even in kind of the Midwest area, really opened up my eyes, because just between not having access to actual hospitals, if even they even have an ICU, that's a whole different area. But yeah, testing and just general information and supplies, they're kind of the last to receive it. So I also think, while there's a lot of improvement, those who have been on either side of the coast, east or west coast, and close to a major urban area, at least somewhat they've been able to mitigate it. But I still think there's a lot of work to do. And when you mentioned South Korea and Italy, for example, even just how their hospitals responded, right? For example, South Korea's drive-through concept, that to me was very shocking that we did not have that in a country and a lot of these urban areas that have such high density of vehicular traffic, or everyone is kind of driving throughout the country, right? So I don't know. That is definitely an area that we'll have to figure out what went wrong and where we can kind of expand that. I'm not sure if you saw even the rapid testing that was approved. It still was a very lengthy process for those companies to actually conduct those tests. So yeah, those barriers, I think, really did hurt us, and I'm sure you would agree that it could have possibly prevented a lot of the cases that we're seeing now and possibly will see in the future.
I think you raised some good points there. Is our lack of preparedness in multiple levels has led to some mixed messaging as
Absolutely.
well. And you can just follow the CDC guidelines and how those have changed over time. They're basing their guidelines off supply and demand principles of economics, not based off the science of, yes, you need to protect the healthcare workers with the most aggressive forms of PPE possible. And yes, maybe people in public might need a certain level of mask to actually provide protection to themselves or to others. But what we're seeing here is we don't have adequate testing. We don't have adequate resources in our public health infrastructure and our preparedness, is that this leads to mixed messaging, and we don't have a coordinated federal response. And so the states are kind of doing it on their own. And I'm lucky to be in California right now because I feel like we've taken aggressive measures to do that. But there's still states right now, as we speak, that don't have a comprehensive, even stay-at-home order.
Exactly.
And if I had to guess, we're going to see some peaking in the rural communities, even though those are not as urban and dense as some of the coastal cities. I think we're going to see a wave of cases, unfortunately, in the next couple of weeks to a month or two as well. And hopefully we get some break with summer coming around. I'm not holding my breath on that, but I think the lack of a coordinated federal response has led to mixed messaging. And so it's really hard to find useful information. Even for myself, a lot of the advice that I give to colleagues and others in public health, I look at what they put out, but then I explain maybe the limitation of that and why we might want to consider doing something else. And then
of course
they update the guidelines. So it's very anxiety producing for everyone. It's for the doctors. We're nervous. Then I think that translates to our patients and the community members in general. And so I'm just trying to work with the best information I have and to disseminate high quality information. But as you can see, it seems to change almost on a daily basis sometimes.
Yeah, and I think obviously just the conversation we're having and providing this has been a great way of providing a vital and accurate information of how how much this virus has really changed. I mean, if you think of when it started initially in December in China to where we are seeing it today, and especially on a global level, where in China we saw, okay, it was affecting populations that were generally elder. That notion kind of carried out here in the U.S. For the first few weeks. There was a lot of talk around young people not paying attention, and those pictures and videos that were coming out of spring break parties and stuff. Those were, and the conversation quickly shifted when we saw places like California and New York have, 50% of their cases are between 18 and 40, right? Young adults, both men and women. And I think, what's interesting to me is you have a research background as well. And, as somebody who I conduct clinical research in asthma and PTSD and just in public health in general, I was thinking, there's so much we learn of what we can simulate in a lab and, what we can do in a control setting. And it's a lot of, just knowledge, and it's hard to replicate this on an actual scale. And I'm not sure how the research experience has really prepared you for this or maybe benefited you in any way. But I think personally for myself, it's taught me a lot of, some of the measures that are really needed prior to and, throughout an outbreak. And so, I don't know if that changed your perspective on COVID-19 itself.
For sure. I'm very happy about having my research background for a couple reasons. One, it's allowed me to critically review the literature. And
Absolutely.
that was stuff that happened hundreds of years ago, looking at that through a historical lens about past pandemics. But just looking at the literature that's coming out in real time about this outbreak, whether it's a new article in JAMA or the New England Journal of Medicine, and then even kind of this controversial, like, for example, hydroxychloroquine, the azithromycin trial out of France. And when I first read that trial, my initial gut instinct from having reviewed many clinical trials, many high quality, many low quality, was, yeah, I know we need to get information out fast, but having a bad trial, which I think that was, it at least was presented poorly, does more harm than not having the trial out there at all. And so that has helped me, communicate to my colleagues and communicate to patients and, worried loved ones about to hear, oh, this drug might be amazing in preventing COVID-19 or improving outcomes with that. And we actually have a president who is kind of touting those
Right.
claims right now. And I hope he is right that we do see some benefit from it. But my instincts and research background say, just using a malaria drug, all of a sudden in this new outbreak that might have some efficacy, it's not going to have a lot. It's probably not going to prevent the illness. But then also looking at the actual way the trial was done and kind of a little shady how they presented the data to make it look like there might be an effect. And I think we're seeing some other trials that are showing that it may be helpful. Most likely it's a null finding, meaning it does nothing really in addition to what we normally do in a supportive care setting. And so research background has, I think, allowed me to stay calmer, but also allowed to calm others in terms of let's not just start taking hydroxychloroquine and azithromycin. And I think it's important to maintain our scientific integrity, as hard as it is sometimes when you get anxious and we're in a pandemic. But that's, I think, more critical than ever right now. These aren't benign drugs, and we don't want to be doing things that actually might end up hurting us in the long run.
Yeah, and I think you bring up a great point on that. And, combining research into, clinical medicine, is that kind of widespread, or are certain, physicians, on the fence of what actually would work? And in terms of the treatment, I think there's been a lot of talk of like creating a vaccine, creating, having this experimental treatment. Okay, we'll do a experimental trial. And, part of the battle I personally faced right now is, communicating that to patients that, science is not overnight. It is, it's not perfect either. And, even with a clinical trial, just the limitations that are imposed within, we don't even know, if what you receive is A, the actual treatment or not, and B, what those actual benefits may be till either the population size is well enough or the results actually show a significant difference. And I'm not sure if that is actually communicated at all. And, if so, it's been done, very haphazardly almost.
Yeah, and as physicians, when we're on the front lines, we want to try something and we want to have hope in a drug. And so, for example, hydroxychloroquine, maybe it will work. Let's take a risk. Let's give it a chance because we see what this disease can do. It can lead to rapid deterioration and a fairly high case fatality rate. So the science sometimes gets pushed aside because what we feel obligated to do something, just providing supportive care might not work. So we throw darts sometimes with different medications or different combinations, trying different things. And through that, sometimes we end up, finding some good best practices, ways of managing patients, but then it's really hard to tease out scientifically
Yeah.
what's the effect of what like an individual component is. And I think we're seeing some of that with the hydroxychloroquine because when people are given that, well, they're usually given a bunch of other medications and a bunch of other treatments additionally. And it's really hard to tease out what each of the individual components did. And to have a meaningful data, we're still probably a couple months away. You need a lot of patients to eliminate that noise there. And so I caution any news that you hear, quickly in these first couple months, I'd be a little skeptical. Be hopeful, be optimistic. I'm optimistic, but don't just jump on it. Don't
Of course.
buy all the stock in that company and whatnot. Just let it digest. Try to use your instincts and kind of see what it's really going on in the data.
Yeah, and I think just in general, I mean, what is the actual treatment that's currently being just a standard treatment? Because from what I've seen personally, is most people don't even understand what that is. There's been just you could take over the counter, flu remedies and cold remedies, and that's clearly not what's being given in an actual ICU or in an emergency room to a patient. So what is kind of that just standard right now? What is being used?
Right. So thankfully for the majority of people, it's what they call mild to moderate. And that could be a significant flu-like illness. And it's a little misleading to say mild. You could be a couple of weeks, very weak, a lot of body aches, a lot of fever. And so what we usually recommend is kind of over the counter. And that's use of like Tylenol, which kind of helps lower the temperature, which helps also alleviate some of the body aches and just the general sick feeling. And then taking in a lot of fluids. So since you've got a fever, you sweat a lot, you lose a lot of fluid volume, and being dehydrated is that one doesn't feel good and also can get a little dangerous. So that's what we mean kind of by supportive care at home. And so if most people try that, and thankfully what we're seeing, at least 80% or so people can manage at home. But then anywhere about 15 to 25%, depending on the numbers we look at, might need some level of medical care.
Of course.
Whether it's coming to the emergency department or urgent care. Sometimes it might just be to get intravenous fluids. You feel a little weak. Sometimes we need to give you some IV saline, give you a little Tylenol, maybe some anti-nausea medications, just get you to feel a little bit better. And then some people go home right away. So that's another level. And then there's people who need to be actually admitted to the hospital. And this is typically because they have trouble breathing, maintaining a certain oxygenation level. And for starters, you typically just give them what we call supplemental oxygen. So we put a little cannula in their nose, delivers a little extra oxygen, helps boost up their oxygen levels in their blood. And for some people, that's enough. And combine that with some pain reduction, some fever reduction, get the nausea under control, give you some IV fluids, a little bit of oxygen. Some people get better pretty quickly in a couple of days and can be discharged home. Thankfully, if you're pretty healthy beforehand, that's probably that will happen to you if you get admitted to the hospital for that short period of time. But there's the more severe components of the disease where people are coming in trouble breathing. You start them on the supplemental oxygen, and then that's not enough. it becomes more labored, like they're physically exhausted from having to breathe to try to get enough oxygen, and they get weak, they're not keeping up their oxygen levels. And that's when we talk about the intubation, where we put actually a breathing tube into their trachea, and the machine is able to hopefully inflate their lungs with enough oxygen to help support their breathing efforts. And during that time, what we're trying to do is we're just trying to buy more time. We're going to support your breathing and hopefully let your body fight the virus off itself. And so we maintain your nutrition levels, your IV fluid levels. We probably give you a little dose of antibiotics to make sure there's not an actual bacterial infection. This is where we're kind of in the throes of it right now, where people are trying different things. What does this work? Maybe it works in this situation. Maybe it doesn't in this situation. A lot of great talk on Twitter and Facebook, even not normally the best place to exchange medical information, but we're working in kind of a real-time
exactly
like type of thing. And then we got some of these investigational drugs where we throw in, hydroxychloroquine, azithromycin. My guess is when you're at a severe level already, those medications aren't going to have much of an effect. But then some of these other medications that you're looking at, some of the monoclonal antibodies like the anti-IL-6, which is an inflammatory marker, we think maybe some of the people are getting really sick just because their immune system is reacting so strongly to the virus that we can actually tone down some of their immune system. That might help them recover a little quicker. That's one of the drugs that's being investigated right now. And then there's another drug that's actually an antiviral replication drug that was developed during the Ebola outbreak, and that might have some efficacy as well. There's been a rapid rollout of clinical trials and compassionate use across the country and world with those drugs. And so depending on the situation you're in and the availability of the drugs, you might get one of those, you might get two, you might get three, neither. And it's really hard to know when you're kind of throwing different things. And when it might seem like easy to, discuss this outside the medical setting. Well, why don't you just get one and see if it works? When people are crashing and their blood pressure is unstable and you don't know if they're going to decompensate really rapidly, you're making these quick decisions because you're just trying to do the best you can. The information you have, you don't know who's going to be able to pull through, who can hold on a little longer. And so that's where the art of medicine that the frontline workers are doing right now can really muddy the scientific clinical research side of things when we're really trying to tease out what actually was it that worked. And then if it is something that we identified that worked, how do we scale that up and identify can benefit from it? Because some of the medications that you give in someone that's 25 years old suffering from this might be different than someone who is 25 or 80 with other medical conditions. So there's just such a long way to go.
Yeah.
Frontline workers are doing great. They're exhausted. They're all running on adrenaline right now. But I worry about, a month or two from now when some of that adrenaline wears off a little bit and we're still fighting this. Hopefully we'll have a better algorithm to work with for patients. But in terms of drug development and identifying effective treatments, I mean, we're usually talking years. Hopefully
Absolutely.
Than that. And then on the flip side of things, vaccination, how to prevent the disease. Hopefully the stuff that they're working on right now has promised to at least offer some immunity, but vaccines usually take a couple of years to as well. And those are the ones that, work. So we'll see. I'm cautiously optimistic, but I just want to let your audience know that the people are working really hard. They're trying to take care of your loved ones as best they can, but there's just so much we have to learn to really get a grasp about what's going on within the healthcare system, and then how do we return to normal life, or what the new normal is going to be.
Of course, and I think especially your background in cardiovascular health and the epidemiology. I'm sure there's been a lot of learning in terms of that. Given the conversations and the crisis around ventilators and just the number of cases, people being intubated and that reliance, and obviously that can also lead to more severe outcomes. I think that's been a real challenge. I'm sure going forward there'll be a lot more attention in terms of not only the medical equipment but also the I don't think people were well informed of the cardiovascular effect itself from the disease. It really took, from the stories I've heard and patients I've seen, it really took them by surprise, given, that notion of, it might be mild to moderate symptoms of a flu. And typically you don't have that collapse or, type of severe breathing issues or anything. So I thought that was like very shocking, right? So
yeah, you bring up some good points there. And some of the severe cases, we're actually seeing cardiac injury
exactly
from the virus or the immune response to the virus. And so there's obviously acute issues related to, one, can you survive that and how do you manage that? But then if a significant proportion of our population gets affected, are we looking at long-term cardiovascular manifestations? And what does that all mean? Are we going to have a higher prevalence of heart failure, for example? I'm not saying we will, but what does that all mean in terms of, disability and being able to work? What does it mean for our healthcare and our resources? So we know nothing about the long-term consequences, right? Because we're only a couple months in, but we got to be planning for that as well and anticipate some of that going forward in terms of how we want to reopen up the economy, what kind of policies we want for healthcare, for public health, all those things. And I encourage the audience to start thinking about some of those things and finding, political leaders and local leaders that at least have a semblance or a thought process in mind of how they're going to approach what the new normal is going to be after this.
Yeah, I think especially, our leaders definitely would need to be more integrated into what our health system needs are, obviously just on a very local level, from cities all across the country and, state level, and all the way up till the federal level. One of the things I learned very early on, being at the National Science Foundation, was the communicating and reporting. Just in the recent headlines of the racial disparities, that was not being reported. It's still not reported accurately, or if at all. Virginia, for example, is a state that, while they're reporting number of cases and number of deaths, they're not reporting the racial statistics behind it. Parts of California, parts of New York have obviously started to push that data out, and we're seeing those disparities. But that's a whole other issue of, social determinants playing into the public health and the resulting impact of now COVID-19 on these communities. And I think in general, given how long this has really stretched out the number of people it's affected, both on a national and global scale, there'll be research and, inquiries into what was good, what was, what we need to learn from. And just, I think the future research, we're talking probably anywhere from 1 to 5, 10 years, if not beyond, right? This is kind of one of those events that will really shake up all of medicine, science. I think kind of touches on all sorts of topics, really, when you look at it introspectively. I think that's very unique, and discussing something like this is very important for that reason. And especially, what I really want to know in your perspective, being at a large institution like UCSD, what has kind of been, the response on their end? What did you kind of learn in terms of what was helpful? Obviously students moved online very quickly, but in general, given the health network that UCSD has and what you're part of, how is that kind of all integral in the successes you've seen so far?
For sure. Speaking of UCSD, and I think a pandemic or a crisis like this really shows if you have adequate leadership or inadequate leadership. And UCSD really stepped up. And I think part of it is because we were actually accepting patients from, I believe it was one of the cruise ships, or that was brought home off a military aircraft carrier. They came to Miramar, and then they came to one of our hospitals. And so we set up, or not we, but UCSD Health set up a emergency response system where you have like an incident commander, and then you disseminate information out to everyone that's working there. And so they were able to start right away developing these protocols. And so that was back in January. And then when it came to March, and, it's like, well, we need to kind of cancel in-person classes, really saw immediate leadership from the University of California, working with the UCSD Health, because, they're different components. We're all on the same campus, but different hats working together. What's safe for our community? What do we need to do in our healthcare system? It's just really inspiring to see what can be done with effective leadership. And I think UC San Diego, and just reading across other institutions, we've had a really excellent, robust response system, and we're, I think, been able to keep our employees safe, our students safe, and really kind of mitigate what could have been a really disastrous situation here.
Of course.
I think the leadership is key, and that buys us time. And just one of the points you were mentioning before about future research ideas and what's going to come out of this, I really hope this highlights when we're talking about like racial disparities. Someone who, like myself, who does a lot of research in health disparities, is already aware of the fact that people in poorer zip codes live 10 to 15 years less than people in richer zip codes. And I know that individuals from African American and Hispanic backgrounds on average live less than their white counterparts. But what this pandemic is doing is it's playing out just like other health disparities. But I hope what this crisis gives us time to do is, in this post-crisis era, is that something that's going to be acceptable to us?
Exactly.
It's in the United States for a long time that it's been accepted. It's like, oh, a lot of people just brush it off. It's like, they've made individual choices that have led them to have poor health outcomes. Well, it's not that simple. It's a play of individual factors, but mainly environmental factors. It's where you live, the type of air you breathe, the type of water you drink, the type of food you eat, the type of job that you work in. And we really need to have a bigger conversation as a society. Is that acceptable to have people that are just going to live 10 to 15 years less than others based off their socioeconomic situation? I find it appalling. That's why I research this area and are trying to get the information on it. But I'm really hoping one positive that might come out of this pandemic is that it allows us to really have that kind of introspection as a society about what we want the post-pandemic society to look like. And I'm hoping it's more equitable, or at least equitable thinking.
No, absolutely. I couldn't agree more. And I think this is just one form of trying to, bridge that gap. Obviously, given the background yourself and I have in public health, the people I've talked to, both on this show and off, everyone has really always kind of brought it together. What we pride ourselves on of redefining healthcare is, that notion of, okay, I'm sick, I need to see a doctor, I need medication. And while that notion was true for decades, if not, for the better part of medicine, modern medicine, I would say that is not true anymore, right? Especially with the changes in, ensuring Americans and making sure access was increased to Americans since the Affordable Care Act. That was really big, and being able to close those racial disparities and health outcomes that people are suffering from, and making obviously just the notion that healthcare is simply not just a clinical issue; it's a societal issue. It's exactly like you mentioned, where you live, what you're doing, your occupation, education. All these various factors are actually what determine your health. The disease, the resulting disease, is actually more of just the outcome of those factors, right? So I think that's very big, and especially dealing with it in a community like yourself, it's a very good perspective for people to have and just put themselves in, right? So it's not, we're not just always talking about a national scale. It's in relation to national scales. Hey, what am I feeling on the level at San Diego, or what am I feeling at the level in Michigan or New York? They are different, and I think understanding those and being aware of it can really transform how the entire country thinks of healthcare, if not the world, right?
Exactly. Good point.
And so I think, which ultimately brings me to the end of this is really just over the last few months, we've definitely seen drastic changes, and I'm sure there's many more to come. But what is your kind of parting advice to people in terms of what they should expect? And, how do you even feel about this? I think everyone, young, old, everyone has different perceptions of this. I would say a large amount of them have a general insecurity, right? What's the future look like?
Yeah, I'm very optimistic, and I know we just spent probably the past hour railing on the many failings and shortcomings which need to be addressed. But I'm very optimistic for the future here. Whether it's just the spirit of community members coming together, like you said, printing masks. I mean, who would have thought that that's what they would be doing a couple months ago? Our ability to get out new information, use existing technology to communicate new information. And there's, issues with going through all that, but we're learning fast and the spirit is strong. And we're a country that's really divided, but hopefully this can bring us actually together to defeat a common enemy. And so I'm optimistic for our long-term outlook in that. So that's how I'm eventually able to sleep every night. The first 10 minutes is being, oh my God, what's going on here? But then I immediately think, well, we're doing the right things. We got great care. And I want people at home to know that, well, all we have really right now is the physical and social distancing. We have to maintain that right now. There's just no question about that. We know that's what works. It buys us more time to figure out all these other things. But combining that, the human spirit is really on display here, and community, even when we can't physically be together. So I want people to take a lot of pride and comfort in the common good and the common goal we all have of kind of defeating this virus. And there will be a lot of ways of arguing about how to best handle that or approach that. And I think that's just human nature in general. But I would say I would leave, and go to sleep after you listen to this podcast. Whenever you do, I would feel optimistic about the future of this country. I think we're on the right track. We got a lot of great people, and that will overcome any of our other shortcomings.
Of course. And no, I think, just us talking, what you're doing on your end and different involvements we all have, I think it's really critical, and they're going to play a great role in, getting through this and also preparing us in the future and protecting ourselves from any other pandemics or health emergencies. So with that, though, I do want to thank you for your time and joining me on the show. And I hope you and your family are staying safe and healthy throughout these times. And, we'll definitely talk soon on hopefully non-COVID related topics.
Absolutely. I enjoyed the chat, and just talking about it, I feel a little better about it already. So I hope others out there do as well.
Thank you so much. I'll talk to you soon.
Thanks for joining this episode of Global Talks by PavLyfe with Pavan Lohia. Make sure to visit PavLyfe.com, where you can also subscribe to the podcast and read the PavLyfe blog for perspectives and news on everything healthcare you simply can't get anywhere else. Share your thoughts on the show by rating the show and by connecting with us on social media. Thanks for tuning in. See you in the next episode.